start in about 30 seconds. Thank you so much for joining us. Again, I'm Andre Bailey. I am the CEO and founder of Project Opioid USA. Project Opioid is a nonprofit organization that works with leaders around America to try to solve the opioid crisis. And we're so honored that you would join us today. A few things I'll tell you as we get started. This webinar will run for 1 hour and we will end on time, no matter what the circumstances. So buckle in for 60 minutes and we will share with you some great information, again, on how your community can look to solve the opioid crisis, which is absolutely devastating communities around America. Let's go ahead and get started. Next slide, please. Again, a huge thank you to the hundreds and hundreds of communities that have joined the webinar. I want you guys to see this quick video. Thank you, Amber. This quick video of what we're seeing across America.
Your daughter's unconscious.
It's the sound of sheer panic.
How old is she?
16. Sophia! Sophia! She's on her back. Please hurry.
Got them on the way.
It was a quiet afternoon near Boulder, Colorado, when Ryan Christoph finds his then 16-year-old daughter, Sophia, barely breathing.
I'm pushing on her chest and it's making some noise, but she's unconscious.
Okay,
and
is she laying flat on her back?
Blue. She's on her back on her bed.
Listen carefully and I'm going to tell you how to do chest compressions.
Within minutes, Sergeant David Cohen with the Lafayette, Colorado Police Department pulls up.
I'm going to count with you, okay? So try and go with the pace I'm counting, okay? Keep up with that pace if you can, okay?
I'm responding with an AED.
Hold on, I think it might be, hold on. Up here, up here!
Upstairs?
Cohen sprinting up the stairs and into Sophia's bedroom.
What is her name?
Sophia.
Let me take over CPR. Sir, does she use narcotics?
Sophia's father telling him he doesn't think so. He only knows of her smoking a little weed. But Officer Cohen's experience told him otherwise.
Lincoln 21, slight pulse and Narcan administered.
As the approaching ambulance gets closer, the Narcan kicks in.
She breathing? She's breathing, yes, sir.
Sophia had taken a Percocet that came from a drug dealer, not knowing it was laced with fentanyl, a synthetic opioid used to treat severe pain that is 50 times more powerful than heroin.
Last year in America, we saw over 100,000 deaths. Sophia was brought back, luckily, but we saw 100,000 deaths. Again, I'm your host, Andre Bailey. This is my contact information. If you want to screenshot this, if you want to get a hold of me later, go ahead and screenshot my information. But I'm your host. I'm also the CEO and founder of Project Opioid. So thankful to the hundreds and hundreds of communities that registered for this webinar. Again, a lot of you might be new to Project Opioid. Next slide, please. We only work with leaders at a community and national level. And so we're happy to have you here. Webinar agenda. Again, we're going to talk about the most recent data, funding sources, and how your community can use funding to impact treatment options. We've got some amazing folks, next slide, please, who are going to be on with us today. By the way, before I get into that, if you have questions, please feel free to put your questions in the chat box. We'll be answering as many questions as we can and then reach out offline with other answers. Today, we're going to also have some wonderful guests, starting with Dr. Kendall Cortelyou, PhD. She's the head of healthcare and informatics for the University of Central Florida, also national data advisor for Project Opioid. I think she's got some of the best data in America on this crisis. We'll talk to her briefly in just a minute. Next slide, please. We're also going to be talking to a couple of our esteemed colleagues. One of our favorites is Harry Nelson, author, The United States of Opioids. He's going to talk a little bit about where the lawsuits are right now and how your community can take advantage of what is now billions of dollars coming in over the next few years. We'll talk to Harry in a second. We're also going to be talking to, next slide, a good friend of Project Opioid, Dr. David Dehimi. Dr. David Dehimi is the head of My Mat Clinic in California. Just one of the smartest guys I've ever met around these new FDA-approved medications that can save someone's life and help them break the cycle of addiction. We're also going to talk about how many of these lawsuits and the funding, national and state funding that's come down, really will be pointed at medication-assisted treatment and why that's something your community whether you're a city, a county, a sheriff, a healthcare leader, why your community needs to use this money to expand medication-assisted treatment. Next slide, please. And as always, we're just so excited to have Ben Stewart on. Ben is a partner with SAS. SAS is the largest private data company in the world. And we're going to talk a little bit more with Ben about some of the new innovations in technology that SAS is starting to put into communities next month to help them impact the opioid crisis. They have a new software tool which allows communities to navigate those who need opioid treatment to help. I call it the Uber or Lyft for opioid use disorder. And Ben will talk about that at the end of our webinar. But let me take a minute, next slide, please, and talk to you about a little bit more about who we are and what we do. Project Opioid, we focus on leaders at a community level like yourself, and how you can impact the crisis in your community. A lot of times it's not about what, it's about who, and that's what Project Opioid does. And that's why we're so honored that you're on with us today. Again, who are the attendees of this webinar? It is only city leaders, county leaders, healthcare officials, sheriffs, law enforcement, and others who have the ability at a community level to drive solutions. So that's who we are, and we want to help you impact this crisis. Next slide, please. That's why we exist, to help leaders around America, because we believe leaders in your community can create solutions and save lives. We have Project Opioid initiatives going around America, and we want your community to be the next community and region that brings your leaders together around this crisis. Next slide, please. I'll briefly just tell you that we do this by creating coalitions, helping you create advocacy, and then helping you move a community engagement for solving the opioid crisis in your community. So as we get started, I just want some of you reach out to us. We get calls and emails from you all the time about how you can join Project Opioid's leadership and how we can help you in your community. Well, I've got some answers for you. Next slide, please. We are going to be doing a new leadership session. We want to help you build your regional solution. Next slide. And we're going to be having a special training session. September 25th, we'll begin our next 8-week community training program. So if you're interested in your community doing a Project Opioid, and we have these all over America, please scan this QR code. We'd love to have your community join us in a leadership capacity. We want to help you save lives in your region. Scan this in, we'll be sending it to you as well. Next slide, please. Again, how can you solve the opioid crisis? How can you spend resources in your community? Let's start unpacking some of the data. We want to look at the data for a minute. Next slide, please. But let me start as we go into the data. I'm going to go through this really quickly. 4 areas, just really quickly, that your funding should be focused on or funding is available for in your community. Next slide, please. 4 areas with funding to focus on. Number 1, fentanyl is driving this crisis. Fentanyl is the most dangerous drug in history. Next slide. It's important to note that this crisis has become a fentanyl crisis. It is no longer a prescription pill crisis. You're watching fentanyl being made in the woods in Mexico by the cartels. What's amazing right now is there are billions and billions of dollars, roughly 50 billion, maybe up to 100 billion eventually being available to communities, largely because, next slide, of the prescription pill crisis. But we've seen the prescription pill crisis transform. And now what you're seeing is the prescription pill crisis has become a fentanyl crisis, killing our young people in unbelievable rates. Next slide, please. Funding is now needed to battle what you're seeing on your screen here, a fake pill and fake drug crisis. Which pill would you pick if it was you? That young lady at the beginning of the video, she picked wrong and she got a fake pill, and that pill almost killed her. This is the new opioid crisis. It is no longer a prescription pill crisis. It is a fake fentanyl pill crisis and fake drug crisis. Next slide, please. Again, some of you know this, but we're seeing lethal doses in record amounts. Next slide, please. And leaders around America have to invest, number three, in strategies that can save lives. Next slide. Just getting your mind working around where funding needs to go and where funding is designated for. You're seeing a lot of states and communities look to create navigation. This is something Project Opioid is passionate about. The bottom line is, if someone reaches out for help in your community, are they going to get help? And that's what's going to matter. And so how can you use funding to impact those in need? We believe this is important. Next slide. Navigating people to need in need to help. And ultimately, Project Opioid believes it's about who, then what. Next slide, please. You must find a way to bring together leaders. And this is what we want to help you do with our overdose initiative starting September 25th. 8 weeks to bring leaders together and for us to train you on how to do the overdose initiative. So excited about that. Scan that in, and we'd love to hear from you if you have any questions. Next slide, please. Without further ado, again, if you have questions, put them in the chat. But without further ado, I'd like to bring on one of our esteemed colleagues, Dr. Kendall Corlew. Kendall, are you there?
I am. Hi, Andre. How are you?
Wonderful, wonderful. Kendall, we've got so many mayors and county leaders and those that work in regions across America on healthcare officials, sheriffs, law enforcement. Kendall, I'd like to give them good news on the overdose crisis, but there's really not good news, is there?
There's really not. Andre, we in my industry, we have been watching these numbers and sadly going just up and up over time. And we just really haven't seen the decline that we were anticipating and we were hoping for once the COVID pandemic kind of moved past us.
Yep. So this was just from a few weeks ago. Drug overdoses hit a new record in 2022. Next slide, please. And we saw the total number of drug overdose deaths top 100,000 for the second year in a row. Kendall, what are you seeing here? And again, this looks terrible.
So what we're looking at here is in 2022, we topped 110,000 overdose deaths in the United States, which is about on par with what we saw in 2021. But if you look at this graph, what's obvious and so striking is just how much the overdose deaths just skyrocketed after 2019 and especially in 2020 during the pandemic. And just to remind everyone that in 2017, when we had about 70,000 overdose deaths, is when this was declared a national public health emergency. So we are just continuing to see things grow. We've leveled off, but really at such an alarming rate that it's frightening.
Yep. Next slide, please. And I think, Kendall, it's so interesting in a tragic way for people to see these numbers. Actually, let's go to the next slide. We see the 300 deaths a day. But Kendall, I think this is the most important thing that city and county leaders could look at right now. If you look at 2015 to now, tell us what we're seeing here in the changing face of this crisis.
Right. It is completely true. This is such an important piece of information for individuals looking to improve the longevity and the livelihoods of the individuals in their community. That brown line that you see there is fentanyl. And that's synthetic opioids, which is primarily fentanyl, which is making up 80 to 90% of the overdose deaths that we're seeing in the United States. If you look at 2015, that brown line was negligible at best, and it wasn't something that we had really seen. But much like the graph that we just saw in 2019 and 2020, you can just see how those numbers skyrocketed, and you can see how other numbers such as cocaine and heroin have started to level off, all because of what we call is polysubstance, which is fentanyl being mixed with so many different kinds of drugs. So in order to really address the overdose crisis in your community, it's really important to remember that this is not the overdose crisis of yesterday. This is not people that are getting pills from their doctor. These are people that are getting pills off the street, that are getting fentanyl put into a variety of substances.
Yeah, and Kendall, next slide, please. What's fascinating is we saw money come in from a prescription pill crisis that now needs to be used for a fentanyl crisis. What are you seeing here in regards to the death rate among those who are very, very young?
Absolutely. This is probably the most tragic piece of data that I deal with. And that is just the really staggering number and increase in overdose deaths of individuals under the age of 24. So you can see, again, back in 1999, this was a minor issue in the United States. But as the time has gone by, we've seen just such a tremendous increase in individuals in this really very vulnerable population. 77% increase in the number of people overdose and dying between 2019 and 2021. It's just so scary.
Yep, and we'll hear more in a minute from Ben and his team at SAS. This is one of the reasons we're so passionate about navigating people to help right when they're struggling, or willing to reach out and get help. When people don't get help, they die, and die very quickly because of these drugs, with many of them being very, very young. Next slide, please. And I know, Kendall, you're going to stay on and answer questions in the chat, but I think this is also important. Drug use is not up.
No.
Drug deaths have skyrocketed.
Completely. Drug usage and drug usage patterns among adolescents has not changed. It's the tale as old as time, right? We have had an experimental relationship with drugs in this country for a very long time. But as you can see, with the integration of fentanyl into the drug supply, the death rate has just, again, skyrocketed, but not because the drug usage behaviors have really changed that much.
Amazing. Next slide, please. And Kendall, I think that was kind of a synopsis of, we wanted to give people a short and sweet version of the data if they haven't seen it. And again, this is why the resources available at the state and national level are so critically important. Kendall, thank you so much. Hang out with us. We'll talk to you more in just a minute. Next slide. We've got some great presentations. I think that all of the leaders on this webinar are going to be impressed by our next speakers. Let's go ahead and move forward. We're excited to have a good friend of mine on the webinar now, Harry Nelson, who is, in my opinion, the finest healthcare attorney in America. He is also the author of the United States of Opioids, Liberating a Nation in Pain. Harry Nelson, how are you doing today?
Good. I'm glad to be with you, Andre.
Wonderful, wonderful. Harry, we got a lot of leaders on today, and a lot of them are, again, asking about the opioid settlements and where we go from here. It's July 2023. Harry, you believe it? Time is just flying by here. You know, we've seen a few things happen in the last few years in regards to this opioid crisis. Number one, we saw the lawsuits, the big pharma lawsuits roll out over a handful of years. Those lawsuits mainly are concluded now. You'll talk a little bit about where they stand and the money coming down in just a minute. But we also saw, and this is incredibly important, simultaneously the prescription pill crisis morph into a fentanyl crisis, where now the deaths in America have, depending on where you measure the deaths from, doubled, tripled, quadrupled. But it's no longer prescription pills that are killing folks. It is now synthetic illicit fentanyl coming from Mexico and the Mexican cartels. So go to the next slide and let's dive into this, Harry. We've got just a few minutes to pick your brain here, but talk a little bit about where you see us being as a nation. You got mayors, county leaders, sheriffs, chiefs of police, folks at a community level on this webinar, Harry, who are looking for resources and who are receiving resources. Where are we at with this current opioid crisis?
So Andre, we have about over 50, maybe approaching $60 billion in settlement proceeds to date. So there's the good news is there's real money here. By the way, that I don't know if we're at the end. There's 3,600 unresolved cases, right? Whenever you look at this, you've got to look at the kind of centralized litigation happening, what we call the multi-district litigation in Cleveland. There's about 2,600 plus cases there. And then there's another 2,400 or so cases that were filed in other state courts. So still a lot of cases to be filed. It's a very interesting question how far this is going to go. But, you know, one of the key takeaways that I hope people will pick up, alluding to what you just said, is that the problem today is worse than ever. And for many reasons, we've kind of moved the problem away from the drug makers and physician prescribing to a toxic drug supply, a toxic fentanyl supply on American streets. And so there's nobody should take comfort that we have all this money, because the problem is worse than ever. And unless we figure out a strategy for getting money out of drug dealers and people importing this from from Asia and South and Central America, I don't think there's going to be the drug makers aren't going to be the answer to all of our problems.
Got it. So we've got about 50 billion in settlement proceeds, with maybe another 20, 30, 40 billion coming potentially.
Yeah, I think I won't be surprised to see this number get close to 100 billion by the time we get done. But I don't think, at the end, I was going to talk about tobacco, where there was over 200 billion. I don't think we're going to see numbers like that. It's just there's not enough money, and I think we'll end up putting companies out of business before we get close to a number above that. But I do think there are some more tens of billions here still playing out.
Got it. Go to the next slide, please. And so some of the cities and counties on this webinar are actually seeing that money come down now. Again, talk a little bit about how these lawsuits played out, Harry, and where they wound up.
Yeah, so these lawsuits, the lawsuits are, it's interesting to watch. I think it's useful to kind of look at the theories that are being used, right? Like the claim, it's easy to come up with theories, right? So the big one was that these were marketed negligently, distributed negligently, that some of the drug makers downplayed the risks, or that distributors turned a blind eye to them. There's this whole interesting question of a public nuisance theory, that this is sort of like a pollution environmental problem, where the market was flooded and it had all these bad effects, that there was fraud here. So a lot of theories, but the reality is, like, even though we do have some bad actors, there's also a lot of powerful evidence that this is a systemic and structural problem, and it's we're running out of bad guys to point to who are actually collectible. But I do think it's useful to kind of look at where we've been, because at some of the litigation that we've had already. And I put together a couple timelines that I think might be just to kind of remind us of how this crisis has played out and sort of where we are. That might be useful. Yeah, and I think what's important to remember is we're about 20 years into this crisis. And by the way, it's interesting. What's interesting to see is, like, we had settlements. 44 states sued Purdue in 2001, 20 years ago, over excessive marketing on OxyContin. We had the government involved in 2002. None of this. Anyone who wants to say that this crisis snuck up on us is kidding themselves, right? There was a lot of this was known, right? It's just that what happened is as you can see, you have a lot of in the 2000 to 2015 period. Mostly it was states and government suing, and then what happened, Andre? If you move to the next slide, you'll see in the last 10 years, it's really been, or last 8 years, it's been all these thousands of lawsuits by local governments trying to get the drug makers, the distributors, the pharmacies, and others to be held responsible for all the costs they imposed on communities. And I think anyone in law enforcement should clearly has had to bear the brunt of that. So the good news is we're seeing monies come in as a result of these two kind of settings where cases are happening, some in state courts, some in this federal consolidated litigation in Ohio. And we've had some big cases, right? Probably the biggest of everyone was the Purdue settlement with 49 states that required Purdue Pharma to dissolve and create a new addiction treatment focused company, Noah Pharmacy. And we've had some good settlements, out there that is funding things. And the big question is, how many more of these are there going to be? Certainly some of the big targets, the Purdue Pharmas, the Johnson and Johnsons, the big distributors, pharmaceuticals they've all paid. It doesn't mean they're done paying. They still have more lawsuits, but we're I would say, if this was a baseball game, we're past the in my opinion, past the fifth inning of the game. I don't know if we're in the seventh or eighth yet, but we there's the good news is there's money to deal with, right?
Yep. Next slide, please. And so as we start seeing these settlements, Harry, talk a little bit about how this money where it's coming from and how it's intended to be used.
Well, so yeah, the hope is to get 70%, that's our target, of money going directly to states and municipalities to be used directly for on-the-ground work for abatement of opioid epidemics. We've had some states like Oklahoma, notably, that invested in research as to try to get sort of understand the problem better. But most of the money, we're seeing is the intention is to get that money on the ground for for needed activities. And the question is going to be how well we do, right, and how much accountability we can expect from the various states to spend that money and stick to that 70% goal and spending that on actually remediating the crisis, right? And how much gets spent on other things, which unfortunately is something we know well has happened in the past.
Go to the next slide. And Harry, it's my understanding that the National Abatement Program, again, which is for those that don't speak legal in legalese, this is how the money is intended to be spent in most of the written judgments. Let me just, Harry, as you go through this for just a second, let me also say that it's my understanding, and correct me if I'm wrong, that some of the money that just started coming in the last few months to cities and counties, that really that's going to continue to flow for roughly 18 years, and with 9 years up front and 9 years on the back, and to fund these kind of programs. Is that what you're hearing?
Yeah, I think that's the I'm hearing the same timelines, and yeah, the goal is to make sure that these funds are spent predominantly expanding access to treatment, right, to addiction treatment, buying and distributing the overdose reversal drug, naloxone, and with some money going into at the community level prevention, education, and trying to do more just to stop the demand or the usage of these terrible drugs by so many people.
Yeah, Harry, it's going to be very critical how we spend this money. Community leaders on this webinar, you've got a great opportunity and responsibility. You're going to hear from Dr. David Dehemi a little later about the power of new FDA-approved medications, Harry, that allow someone in their own home to recover and stay safe from these deadly drugs. Let's go to the next slide, please. But again, there's always the fear and the danger that we're not going to spend the money right. Talk about some of the states that you've studied and what you're seeing in these states.
We're, it's every state looks a little bit different, but as this slide shows, in New York, there's a big fight going on. Should the money be at the state level? At the local level. I personally am encouraged, for example, when I see states like New York, where 46% is going to cities and counties, municipalities, with only 17.5% at the state, because I don't have to tell the people on this webinar, the hard work is really on the ground. And so that's positive, right? That's not everywhere. In West Virginia, just to use a contrast, only about less than a quarter of the money is going to local on the ground institutions, and they put 72% in a statewide fund. So likewise, Oklahoma did something similar. So it's really all over the map how it's working from state to state. Personally, Andre, I think we get more accountability. The problem at the state level is there's so many needs that go far beyond this crisis and have nothing to do with it. People got to do there's work to be done on roads and infrastructure, and this becomes a very attractive pot of money. And my fear is that we don't actually put the money where it's needed on the ground if we leave it at the state level.
Got it. Next slide, please. And there's again always the fear that we replicate what happened. There's always a fear that we replicate what happened with the big tobacco settlements, where I think most experts would agree that we didn't necessarily spend that money to effectively impact the issue that the lawsuits designated it for. Is this your fear here?
That's my fear. I by the way, I don't mean to be too lawyerly. I used CF means compare as a lawyer term, and I point that out because 25 years ago we had this $206 billion settlement, and the reality is that money was used for a lot of plugging a lot of holes in state budgets, and how much it was really used on the ground is frankly disappointing. And the problem is that the risks of opioids are much more immediate and severe than smoking. Smoking is a long-term risk, but opioids are direct, immediate overdose deaths and just the cost of overdoses, and the harm, the suffering that's going on is so much worse. And so we cannot let that same thing happen. And I'm very, by the way, I put this on the slide. I'm very troubled that only 13 states have made a commitment to report their spending to the public, all their spending. And a lot of the settlements being reached do not require them to fully disclose those numbers. And I think we've got to hold, one thing I'd say to everybody on this call is we've got to hold the fire to the feet of the people negotiating the settlements, to the lawyers and the state government, the elected officials who are doing this, because this money has to get onto the ground. The money's not going to solve the problem, but we just need to be able to expand access to care and do these other things. And we're not going to get there if we don't get accountability on these funds.
Next slide, please. Harry, if people need to get a hold of you, first of all, I'll just say again, if you have not read The United States of Opioids, you definitely want to pick up a copy of that on Amazon. I think if you're trying to put together policy at a community or state level, or look at federal policy decisions, I think it's an incredible tool. But Harry, is this a good way for folks to get a hold of you if they have follow-up questions? Yeah, that email is the best email to reach me, and I'd be glad to try to point people in the right direction or share ideas. As Andre, as I know, Project Opioid has really led the way on. We've got to do more. The bottom line is this money isn't going to be enough. It's going to be focused on immediate needs, and we have real long-term work to do in all of our communities. And if I can be a resource in that long-term fight, I very much would be honored. So as you heard from Harry Nelson, roughly $50 billion designated in the current lawsuits, maybe another 30, 40, 50 billion coming in the years to come. And then that's it. So the decisions you make in your community right now, with money that's starting to come in, it is going to be critical. And we think that there are ways that you can invest this money to save lives. And we're going to talk about more of those in just a minute. Harry, thank you so much, man. Thank you for joining us, and we'll talk to you again soon. Pleasure. I am here with a good friend of mine, Dr. David Dehemi, MD, out of Southern California. He's going to talk to leaders today about understanding medical treatment options for opioid use disorder. In short, so many of the leaders that we're talking to right now around America, whether you're a mayor or you're an elected county official, a sheriff, law enforcement, healthcare officials, those of you that work for an elected official, you've gotten resources. You now are seeing money start to come down, like Harry Nelson was just talking about. You're seeing this lawsuit money come into your community for the first time just a few months ago. Many of these dollars have been earmarked for what are referred to as medication-assisted treatment options. Dr. David Dehemi is an expert in this topic. So we're just going to take a few minutes with him and talk about this. Dr. David, are you there?
Yeah, I'm here.
Wonderful, wonderful. Where are you today?
I am in my office at home in San Clemente, California.
Got it, got it. You're in beautiful California. I guess it's hot everywhere around America this week, but California, it's always hot, but it's cool at night there. So we're a little jealous. Dr. David, talk a little bit just for a second about who you are and the work you do and how long you've been doing it.
Yeah, so I kind of wear two hats. I'm for my formal training as an anesthesiologist, and I do anesthesia related roles in a hospital, outpatient surgery centers. But about 10 or 11 years ago, I became interested in what was sort of the beginning of the opioid crisis as it was shifting from pills to heroin, or beginning of the second phase. And since then, things have only gotten worse and so much worse. And so I run an outpatient medical clinic that specializes in medical treatment options for people that are suffering from opioid addiction and alcohol as well, but mostly opioid addiction. And we have these very effective treatments that can help basically improve the chances of somebody who's addicted to opioids not only stop, but the relapse rate for these folks is much lower than those who are not on these medical treatments.
Got it. Well, let's dive into that for just a few minutes. Next slide, please, and talk about how you are impacting the opioid crisis using FDA-approved medications and how new resources are available to every city and county that's on this webinar to do the same. But David, first, talk a little bit about, again, the changing and evolving overdose crisis. We look at a chart like this, we see, less than 25,000 deaths right at the turning of the year 2000. Now that's up over 4 times that previous amount to over 109,000 deaths. I think you were saying to me before we logged onto this webinar that it's not just that the numbers have increased, they've increased for a reason. Talk about that. Yeah,
so I got involved around 2011, 2012, and the overdose deaths had surpassed automobile or motor vehicle accidents as the #1 accidental cause of death in the United States. And things have only gotten so much worse since then. And the main reason for that is at the time that I got started in 2011-12, it was pills and heroin that were driving most of these overdose deaths. But what happened in about 2018-19 is those illicit drugs became replaced by much more powerful illicit synthetic opioids, like illicit fentanyl, which are manufactured predominantly in Mexico. And we've seen the results. Instead of a linear increase in deaths, we have, what looks more like a hockey stick or a logarithmic increase in deaths. And one of the main things about why that's happening is, #1, it's so much more potent. So the amount that it takes for somebody to overdose and die from not breathing is much shorter. But the bigger problem is these illicit drugs now are contaminating the entire drug supply. So people that never intended to use an opioid like heroin or a pill like OxyContin, they want to use some other drug recreationally, they're now being poisoned because fentanyl is essentially in all drugs. And so many of these deaths are people that they're trying to use something else and they end up dying as an accident. And that's one of the biggest changes that's occurred in the last 3 years. And unless we start raising awareness and providing medication options, we can anticipate that this is going to stay the same or get worse over time.
Yeah, we hear many of the mayors and elected leaders and sheriffs on this webinar. They're always emailing Project Opioid, asking, how do we bring this death rate down? And I think for some of them who have never implemented a medication-assisted treatment program, this is going to be enlightening to them. But go to the next slide, because you were talking a second about how the wave of opioid deaths, basically, how there's been a big change. What does this chart tell us?
This chart tells us it basically breaks the 3 waves of the opioid crisis into their segments. And the one we were just talking about was with illicit synthetics, it's causing the massive increase in numbers of overdose deaths is depicted by the purple line. And you can see kind of how heroin and prescribed opioids like OxyContin have leveled off or even gone down. But what's happened in the meantime is that illicit synthetic opioids have gone up dramatically. And these drugs are the #1 cause of death of all causes of death for 18 to 45-year-olds in the United States. And if you even combine, motor vehicle accidents, suicides, firearms, they still don't come close to the amount of death that these synthetic opioids are causing. And again, this is the main reason we're discussing this, is like, what are the things that we can do about that? And we'll get into that, I guess, in a moment.
David, you're not, you don't work for the DEA. You're not stationed at the Mexican border at Customs. But would you say that as we look at that purple line here going from 2014 and then just skyrocketing up 2015, 16, 17, and all the way up now to where it's as high as it is in 2020 and 2023, our current year. Would you say that this is the result of fentanyl just flooding the market? Is that what we see on this chart?
That's exactly right. Fentanyl is flooding the market. Fentanyl can be made 24 hours a day, 7 days a week in illicit labs in Mexico. And because such a small amount can be mixed into a larger drug supply, it's much easier to get into the United States. And this is all happening because of profit motive for the cartels. Essentially, if they can hook people that wouldn't normally be opioid users on fentanyl and turn them into opioid users, then they have more people that are paying to buy these drugs illicitly.
And David, is it fair to say, again, we know cities and counties around America are battling this. It's probably fair to say that fentanyl is in all 50 states, District of Columbia. Fentanyl is everywhere in the United States now, most likely, right?
It's everywhere in the United States. And last year, according to the CDC and DEA, enough fake pills and powder were seized to kill more than every single person in the United States if you broke it into individual doses. And if that's the amount that was seized, how much was not seized? And I would think a lot more. So this is a tidal wave, and we are very much behind where we should be in terms of providing treatment options, because that's really the only choice we have.
You got it. Let's go to the next slide, because I think this will also illustrate what Dr. Dehemi is saying. Heroin has killed a lot of folks in the United States, but what you show here on the right is that fentanyl, many people have seen this, but you see it firsthand as someone who is obviously has medical training. Fentanyl and its derivatives, really, when someone encounters a lethal dose of it, without some medical remedy, they have no hope. Is that a good way of saying it?
Yeah, for most of them. I mean, these aren't being mixed into the drug supply in a careful way. And the other thing to keep in mind is that most people who aren't intending to use an opioid also have no tolerance to opioids. So if somebody wants to use, for example, cocaine at a concert event, and that cocaine happens to have fentanyl in it, a tiny amount is going to be enough to cause them to become unconscious and stop breathing. And this happens within minutes. So if you don't have the overdose drug like naloxone available immediately, most of these people are just going to die.
Within 10, 15 minutes.
Yeah.
Could ingest the pill and be gone.
Yeah, and unfortunately, what's happening is all during that time, they're experiencing brain and organ damage. So sometimes even when we do get to these people and we resuscitate them and get them breathing, permanent damage has already occurred.
Amazing. Go to the next slide, please. The power of these drugs. I want to talk for just a minute about addiction and neuroscience. I know to some people that this gets a little bit, that the information can be overwhelming, but go to the next slide. I want to talk for just a second about how someone's brain, let me boil this down for the listeners, a lot of the mayors and county leaders and sheriffs and others who are on right now. David, talk a little bit about, so much of the time when we're thinking about helping people who are struggling with drugs, we like to have this idea in our head, and it's a good idea in theory, that if someone's struggling, they need to make better choices. They need to choose to get off drugs. Talk for just a second about, because of the power of fentanyl in the brain, just how difficult that can be for someone when they start taking this drug, sometimes even unknowingly.
Yeah, so what happens very quickly is changes in the brain occur where the brain says, well, this is way too much dopamine to be healthy. And so the brain compensates by down-regulating the dopamine receptors, meaning making them either less activated by dopamine or fewer of them, or both. And what happens is when somebody starts using drugs, very quickly these changes occur, and it makes it incredibly hard for them to stop. And the behaviors that we see, the behaviors that we don't like, that are the drug seeking, drug using, the what we would call sort of bad drug behaviors, are driven by this process. And so part of the, well, actually not just part, the main sort of crux of what our treatments do is they take this problem and they push it back towards a normal balance, so that people that are having intense cravings or feelings of withdrawal can basically feel more normal, and then their higher brain areas, like their cortex, can then weigh decisions better. Because when you're in the throes of addiction, you're not weighing consequences anymore. Your behavior is driven by survival, because you feel like, if I do not get this drug, I am going to die. And so that's where many of the behaviors that we see and don't like are why they're occurring, for example.
Got it. Let me skip ahead here, go to the next slide. We just want to, again, this is what you were talking about, when someone's brain, and this is cocaine, traditional cocaine, right? This isn't even fentanyl. So what are we seeing here, Doc?
Yeah, so all of these drugs work to reinforce behavior at the midbrain, and it's driven predominantly by dopamine. And so on the far left, the red depicts a normal dopamine receptor concentration in the brain. And after only 1 month of cocaine use, you can see that those dopamine receptors are all but gone. So this drives the behavior. They have to use increasingly higher amounts of cocaine or whatever drug, because they all work through the same exact mechanism, to not feel intense craving, feelings of withdrawal, dysphoria, which means feeling horrible. And then even after you stop, in this case, for 4 months, you can only, after 4 months, you can see that only some of those dopamine receptors are now starting to come back. So the recovery takes a long time, and that's where these drugs are very, very helpful in helping people stick to abstinence and maintain sort of a life without drugs, so that their brain can heal over time.
Got it. Let's go to the next slide, and let's talk a little bit about the clinic. This is the flip side. And when you were talking just a second ago about these drugs, you're now referring to drugs like Suboxone, buprenorphine, Sublocade, FDA-approved medications that many of the communities that are on this webinar now have funding or could get funding to give folks who are struggling. But talk about this slide right here. With these medications, people can have their brain given back to them, if you will, to make better choices.
Yeah, you don't get 1 month or 4 months or 14 months of abstinence without taking care of the cravings. And these people are spending every waking minute of their life trying to figure out, should I use or should I not use, because I do not feel good. And if I just use, I will feel better temporarily. And what the medications do is they make them feel better right now without having to use. And one of the best things about these drugs is, especially with opioids, is that any use can lead to overdose. And they block the receptor in such a way that even if the person does use an illicit opioid, the chances of them relapsing or overdosing as a result is extremely low. So they're a protection, they're a safety net as well.
Got to go to the next slide. I want to try to get to your clinic here. Let's go through these really quickly. We won't spend much time here. We'll put a lot of this in the chat box. But, you know, Dr. David, it's really amazing in the past 6 or 7 years, fentanyl has flooded the marketplace, but there's also these new medications that are giving us some hope that we can use medicine to fight.
Right. So the medications like buprenorphine, methadone, and naltrexone, they're not new. They've been used in other countries to great success. Many countries that had a problem in Europe, for example, with an opioid epidemic, now do not have that problem because they expanded access to these medications and encouraged regular doctors to prescribe them. What's new are the injectable forms of these medications, which I can talk about because they're even more effective than the oral forms of these medications. And one of the main reasons is there's much greater adherence to a once-a-month injection where decision-making is really taken off the table for the patient. They just got to make one decision a month. Should I have my next injection, versus multiple decisions every day where things can go wrong. So MAT is medication-assisted treatment. And when we're talking about MAT for opioids, we're talking about MOUD. That's a newer term. It means medications for opioid use disorder. And the main one we prescribe in our clinic is buprenorphine, because it can be prescribed from an outpatient clinic. And this allows more people to basically just opt for it if they want to. They don't have to go to a methadone clinic where there aren't many of those, and the waiting list can be very long. Plus, it gives them the freedom. Once they have their prescription or their injection, they're free to go and live life and have jobs and kind of repair the damage that their drug use has caused.
Go to the next slide, please, because I want to show this photo of what people might see if they go to your next slide, please. I just want people to see. Well, let me just show this real quickly. If you talk about these medications that can save lives, they're not available much. Next slide, please. At least one service available, all 3 forms of MAT, so rare. So this is very, very rare, but go to the next slide, because I think what I want these mayors, county leaders, sheriffs, healthcare leaders, those that lead insurance companies around America to see is, if someone were to go to your clinic, I've been to your clinic in Southern California, your patients, they don't spend the night at your facility. They don't spend tens of thousands of dollars a week on treatment programs that are sometimes not effective. They get FDA approved medications that can keep them or someone they know alive in case of an overdose. Those orange boxes are something called Kloxxado, which we call double strength Narcan, because everyone knows Narcan. So that's Narcan, naloxone in double strength form. But in addition to that, Dr. David, and I think this is when I talk about the evolution of medications that community leaders that are on this webinar could use resources to fund and save lives. It's really these newer forms of buprenorphine. Go to the next slide, please. You have been someone who has really pioneered extended release buprenorphine. We don't have a ton of time to talk about this, but what have you seen when someone, first of all, I've been to your clinic, Dr. David. I saw with my own eyes folks who had been addicted to drugs 10 years, 15 years, been in prison, and never had figured out how to get out of that cycle. And this once a month injection really saved their life. What are you seeing with these newer forms of MAT and their ability to impact a person and a community?
Well, you just said it really well. Nothing worked for them prior to them getting the injection. And the reason is number one, the decision making. They don't have to make a bunch of complicated decisions every day about whether they take their pill, don't take their pill, take more. It's a once a month injection. Number two, it provides a safety net where if they do sort of have a moment of weakness and use, it doesn't mean that all the wheels fall off. They don't overdose. It doesn't even work. They experience no euphoria from it. They also work really well because it's stable blood levels for 1 month or more. Actually, after the shot, they have a continuous level of medication in their blood. There's no fluctuations that they can perceive. And that, again, allows their brain to focus on other things that are important, the behavioral things that are important to long-term recovery. And the success rate we have with these medications is north of 70%, meaning at 1 year, if somebody got the shot, they are still not using opioids and they are still in recovery. And when you compare that to abstinence-based recovery, talk therapy with no medication, less than 5% of people at 1 year are still in recovery without relapsing.
It's amazing. Go to the next slide. I want to make sure people get your information, Dr. Dehemi, because you are someone who is, and again, we have all kinds of videos we're going to put in the chat and send to you guys in the follow-up emails. But go ahead and take a photo of this if you're on this webinar. Dr. Dave Dehemi is one of the best MAT experts, medication-assisted treatment experts in America. And let me just say this one more time right before he goes. He'll be available later on for questions, but let me just say this: Mayor, Sheriff, county leaders, you can do Dr. Dehemi, is it fair to say, I don't want to be hyperbolic here, but is it fair to say that with the right investments into medications like buprenorphine, Sublocade, these longer lasting injectables, having Narcan, naloxone, Kloxxado available, that a community could literally cut its death rate dramatically, very quickly? Would you say that that's true?
That's what we've seen in virtually every country that's fully adopted this, is not only do they cut the death rate, the crime rate goes down, the expenditure from the city, state, and government goes down, like less ER visits, less homelessness, more people working and contributing to the tax base as opposed to using the tax base for incarceration, for example. It's one-stop shopping for communities to basically solve their problem, to move in a direction with less deaths and less cost and less of all the stuff that comes along with using drugs.
Amazing stuff. Dr. David Dehemi, MD, the head of My MAT Clinic. You can find him all over social media and use this QR code to learn more about him. And again, what we want to encourage you in your community, pull some of these available funds and direct them towards expanding FDA approved medications. I know there's a lot of conservatives on this webinar. We appreciate your passion. I'm here to tell you, as someone who gets these questions all the time, these medicines are not going to be trading one drug for another. They're not getting people high, quote, end quote. They are a lifeline to give someone their brain back. Dr. David Dehemi, thank you so much for joining us, and we look forward to talking to you again soon.
You're welcome. Thank you for having me.
We've got about 11 minutes left. I am not going to keep you guys more than 10 more minutes. Again, we've got so many questions. Go back really quickly. We've got so many questions in the chat. I just want to cover a couple of them. Number one, anonymous, is the distribution of fentanyl test strips important? Fentanyl test strips are critical. You have lots of money in these settlements for fentanyl test strips, and they're becoming legal. Florida, as one example, just legalized them last week. So fentanyl test strips can be very important. Heather was asking about the 8-week leadership program. It is not physical, it's virtual. And so anyone interested in that, we'll give you more information in a second. Nathan was asking about where he can go in his community to learn about applying for these funds. Every state, every community might be a little different. We're going to reach out to you and have you reach out to us if you're asking for specific questions on your state. We are very interested in helping you, and that's going to be a part of our 8-week program. And then, we've got a question from Christine about programs that use multidisciplinary approaches to treating pain. Listen, it's a huge question. What do we do about those in pain now that prescriptions are harder to get? We've got to come up with new ways of making sure people that need prescriptions get them. And that's going to be important. A couple more questions here. Vivian was asking, what's the most effective thing we can do with our opioid settlement money? Drug addiction treatment costs, Narcan supplies, community paramedics program, social workers. I will just say this, Vivian, join our 8-week program. We're going to go deep into it, but I also want to say medication-assisted treatment is so affordable, especially buprenorphine, Suboxone, Narcan, Kloxxado, overdose reversal drugs, so important. And I would say, I think we have to reconsider investing tremendous amounts of money in inpatient behavioral health. So many more questions. We're going to try to answer some more, but we've got just a few minutes. Let me go to Ben Stewart. Ben, are you there?
I am. Can you hear me?
I can. Ben, where are you at today, buddy? Look, you got some pretty skies behind you.
Tallahassee, Florida. Good to be home.
Oh, wonderful, wonderful. So Ben, we've got just a few minutes, but I think a lot of our cities and counties on today, we've got over 400 communities that joined us today, with another 300 joining us post. Ben, people are saying, what can we do right now with some of this opioid settlement money that's coming in? Others are learning how to apply for this money. And I would say, I'm biased because I'm such a fan of this project because I was a part of working on it. But Ben, SAS has worked on, next slide, please, a new software that I think is incredibly important. And, for just 2 minutes, we're going to talk about data and how data can help solve the opioid crisis. Next slide, please. Ben, as you and your team at SAS is the largest private data company in the world, when you were looking at data around the opioid crisis at a community level, you guys figured out there's some things that needed to be different, right?
Absolutely. The problem that we had is everything that we were doing was too late. It wasn't data that was coming in real time to us. So we had a good look at what happened, but we weren't really getting ahead of what is happening. And how do we take these moments that are so important in people's lives and very quickly direct them to an option that isn't 6 months, a year too late.
Yeah, Ben, we heard from a parent who stressed to us, you've got 6 minutes or less when someone's reaching out for help. And that's why I'm so excited. Next slide, please, about the new software that you guys have created. Next slide, please. The regional overdose software that looks to take all of the resources in a community, catalog them, and then figure out how, when someone's struggling, imagine someone struggling with opioids, their family wants to help them, they don't know where to go. And then when they do reach out for help, it's impossible to find that help. What we want to do is partner with SAS as they launch this new overdose prevention software. Ben, I know I'm a layperson, but to me, this is the Uber or Lyft concept for someone struggling with opioids. You don't necessarily, if you don't know the resources available, you've got a very small chance if you're looking in that moment to get help. Ben, how do you feel like this software that SAS is launching in the next few weeks can impact a city or a county?
Absolutely. Well, it's individualized and it's timely. I think those are the two big things that we notice need to be different. So when I say individualized, what we do is we're looking at risk based on the person, not based at a macro community level. Now, of course, when we look at how are we going to spend our time, where are we going to put people to be most impactful in the community, we look at some of those larger metrics. But this is what's happening with the person based upon where they are, what they need, and what are the resources available to them right away.
Got it. And the next slide, please. We've got so much more information to share with folks. We just wanted to give them a little bit of a taste of what's coming. Ben, I know you are going to be hosting, and you've been hosting, some information sessions on this software. Again, I couldn't be more passionate about it. We encourage everyone, screenshot this QR code, use this QR code right now. Ben is going to be hosting in the next few weeks and in the months to come information for cities and counties who want to be a part of the launch of their new opioid software. Again, so someone in need has access to every resource in a community, powered by innovation, technology, and the incredible tools that SAS offers. Ben, thank you so much for joining us. We're going to get more information to these folks via email after this, and we're so excited that you're going to be empowering communities to impact those in need, one person at a time.
We've learned a lot from you and your team, so thank you for having us.
Wonderful. We just got a few minutes left. Let me just kind of whiz forward here in the last 3 minutes. We want to help you solve the opioid crisis really quickly. 5 things you need to invest in as we wrap up. Number 1, money is available. Next slide, for you to consider expanding the lock zone everywhere. Next slide, please. You can use these resources. They're in the abatement judgments to get Narcan. Next slide, please, as well as Cloxado. We want to help you connect with that. Number 2, medication-assisted treatment. Write this down. Mayors, county leaders, sheriffs, chiefs of police, healthcare officials. Nothing you can do is more powerful than investing in medication-assisted treatment. It is affordable. It is not expensive, and it is life-changing. Next slide, please. We need to see more of this available in your community. That's why we want to teach you how to do this in our overdose initiative, in our 8-week program. This is the first 8-week program of 2023. We're excited about it. Next slide, please. We want to help you build a coalition, look at your data, and help you put your strategy together. In conclusion, number 3, education, education. Next slide. Young people are dying. They don't know the dangers of these drugs. That's why, as part of our 8-week program, we're also going to be sharing with you advocacy campaigns you can use. And finally, collaboration. You've got to have the right leaders at the table. Nonprofits, I love you. Government, I love you, but you can't do it alone. We've got to get the entire community in your region involved, with a special emphasis on business leaders, those in philanthropy, and the faith-based communities partnering with government, healthcare, nonprofits, criminal justice. So exciting. Next slide, please. As we wrap this webinar up, so much we pack into 1 hour, but at the end of the day, all of this money has the ability to create a navigation system. This is what the SaaS software does as well, to target the most vulnerable. Next slide, please. Just a couple things as we kind of wrap up this webinar. Lead with compassion. When you meet folks who are struggling with drugs or families who have lost family members, these are good people that wound up in very challenging situations. And so compassion is key. Next slide, please. We see these stories over and over again. This is someone that we share. His parents have asked us to share this story, Justin Forrester. Justin is one of the 100,000 folks who lost their life in 2022, a good young man who was doing well. He had one bad day and lost his life. Folks like Justin, we can get more help and keep him alive. Next slide, please. And that's what this is all about. With our last 60 seconds, again, scan this in, join the Overdose Initiative. We're capping this out at 25 communities. We've already got about half of those signed up. So please join the Overdose Initiative. We want to train you on how to get money, how to build an MAT program, how to do navigation, how to build a leadership team. Make sure to sign up for that now. Next slide, please. And as always, we are passionate. Get involved with us. Contact us. Next slide, please. With our last 60 seconds, I want to just go back and thank Harry Nelson. Back up one slide, Amber. With our last 60 seconds, let me give people the information on us. Again, thank you so much to Harry Nelson, Dr. David Dehemi, Ben Stewart from SAS, Dr. Kendall Cordelew. And let me just say this last thing with the 30 seconds we have remaining. Mayors, county leaders, those that work in regions around America for government, healthcare officials, sheriffs, law enforcement. If you're on this webinar, you have the power to bring your community together to use these important resources, $70 to $90 billion coming in the next few years. You can use those to save lives and transform your community. Again, we would love to help you. My name is Andre Bailey. I'm the CEO and founder of Project Opioid. Our 1 hour session is over. Thank you so much for your commitment to save lives around America, in your state and in your community. We look forward to talking to you and seeing you again soon. Thank you and God bless.